Thank you so much for the invitation. So I'll be presenting a case series on what is a rare variant of intra-articular metacarpal hip fractures in adolescents. So these are relatively rare, and it's poorly understood because the available literature on this variant of metacarpal hip fractures is scarce. So McElfresh in 1983 reported that only 4% of intra-articular metacarpal hip fractures were coronal in nature. The diagnosis is challenging as it's difficult to appreciate them on standard hand X-rays because of the fracture plane. So this was a 13-year-old who presented to me. He had injured his finger after a cricket ball had hit the volar aspect of his finger, causing the MP joint to go into hyperextension. So the standard hand X-rays of a PA and oblique view revealed a Salter-Harris 4 coronal fracture of the second metacarpal hip. The fragment was displaced proximally and volarly. So notably over the lateral X-ray that showed the displaced volar segment. So I used the dorsal standard approach to access the metacarpal head. So these demonstrate the intraoperative view with the wrist oriented towards the top of the picture and the fingertips pointing below. So you can see that the fracture line is just barely visible. And on the right picture, I've used a ragnal retractor to distract the dorsal fragment. However, accessing the fracture fragment, which is at the bottom of this fragment, it was very challenging because of the collateral ligaments imposing space constraints. So in order to overcome this, I used the volar approach instead. The flexor tendons were mobilized, and then the volar plate was divided, the fracture fragment was identified, and then reduced with a Ferreyra elevator, and that was, the fragment was pushed distally. So after successful reduction, I held the fracture with 2 cross-K wires introduced from a volar to dorsal direction. The wires, the hand was then immobilized in a plaster slab, and the wires were removed after 4 weeks. Then the rehab was commenced with active range of motion exercises. So this child achieved excellent functional outcome with full range of motion gained by the 8th week mark. This second case was of a 16-year-old boy who presented after falling off his skateboard and breaking his fall with the left hand. The initial X-rays revealed a minimally displaced intra-articular fracture of the second metacarpal head. He was treated conservatively in the emergency department with a plaster slab. And then the X-rays were repeated at 11 days. And this revealed a 1 millimeter step off in the fracture, which is visible on the oblique view. The parents had elected for conservative treatment, and then follow-up X-rays at the 4th week had confirmed fracture union. However, 4 months after the injury, the patient reported a persistent bothersome click in the second metacarpal during hyperextension. So a CT scan was performed to evaluate this fracture further. So this revealed a malunion of the coronal head fracture with a step deformity. So intraoperatively, exploration showed the intra-articular coronal ledge that spanned the entire width of the metacarpal with a 1.5 millimeter overhang. And this overhang caused impingement of the dorsal base of the proximal phalanx during hyperextension, and this reproduced the patient's click. So to address this, a corrective osteotomy was performed using an oscillating saw. The dorsal fragment was recessed and then stabilized with 2 interfragmentary screws. Post-operatively, the clicking had resolved. So revisiting the initial films, a double shadow sign was noted on the PA view, and this corresponded to the misaligned distal edges of both fragments. This sign would suggest the intra-articular coronal ledge. So we would recommend a CT scan to evaluate the metacarpal head configuration if the double shadow sign is seen on the X-ray. Now, this last case is of a 14-year-old boy who presented with pain in the right second metacarpal phalangeal joint after playing floorball. He didn't report a significant traumatic episode apart from just holding the floorball stick with this particular hand in the forward position. And after the game, he had experienced pain in the joint. So he also experienced this clicking on second MP joint hyperextension, which he noted on the day of injury. But however, he delayed seeking treatment for a month. So the X-rays revealed a sharp corner on the ulnar aspect of the metacarpal head seen on the oblique view, but there wasn't really an obvious fracture. And the second metacarpal head appeared to be a little bit more squared on the PA view, and you can compare the outlines of these two bones on the right side between the second and the third metacarpal. So these are very, very subtle findings, which raise suspicion for an intra-articular fracture. So I did a CT scan straight away, and this confirmed the presence of a cortical step on the second metacarpal head, which confirmed my suspicions for an intra-articular fracture. However, after thorough discussion with the child and the parents, they had opted to leave this alone. So at 9 months of follow-up, the child still had a persistent click of the MP joint or hyperextension, but he did not seem to be bothered by this, so we decided to leave it alone. Now, how do these coronal fractures arise? So we propose that based on the histories given by our patients, that there is an axial force that's transmitted through the metacarpal head with the MP joint in hyperextension. And this generates a shearing force directed volarly, leading to the coronal fracture of the metacarpal head. So in summary, diagnosing coronal metacarpal head fractures can be very challenging. A high index of suspicion is crucial. So clinically, patients often present with a distinct clicking sensation during MP joint hyperextension. They might be completely asymptomatic if the MP joint is flexed from a neutral position to full flexion, but the click occurs in hyperextension. And then subtle X-ray features should be noted. One is the double shadow sign, if you happen to see it on the PA view, and the other one is squaring of the metacarpal head. So when you do get these three signs, do consider a CT scan for those suspicious cases. Thank you.
Okay, thank you, Dario. Thank you for your good presentation with great surgical cases. Seems to be difficult to treat for the malunion. Okay. Any questions? And you presented a case with good fixation with two cross K wires.
Yes.
Do you have any other choices with headless screws?
We do have headless screws, but I didn't choose to use that in this specific case. I think for our institution, at least the headless screws are only available if we ask for them ahead of time. We don't have them consigned to the hospital. So this was an emergency case. I wanted to get in on the same day because I was afraid of avascular necrosis of the fragment. So what I had on hand were either the normal interfragmentary screws or the cross-K wires. But this child was young, and then this particular fragment was right next to the vices, so I didn't want to risk it with interfragmentary screws for that patient.
Okay, I see. I understand. Okay, any questions? Okay. You left the K wires out of the skin, or how long did you keep them?
Yeah, for that child, I left it out of the skin, but they were emerging from the skin dorsally, so I was careful to ensure when they were coming out on the dorsum that the extensor tendons were retracted. And for this child, I thought that if I had started range of motion exercises immediately, it might have been painful due to the impingement of the wires on the skin. So we just immobilized him in a slab for 4 weeks, and then I pulled it out at 4 weeks.
Okay. Any other questions from the audience? Okay. Okay, thank you. Thank you, Dario. Okay, that's all. Thank you for three presenters, Dr. Apavascha and Dr. Lorenzo Garagliani and
Thank you.
Dr. Daryl. Thank you. Thank you very much.
Thank you all.
Thank you.
Okay,
Thank you
and
so much for the invitation to present today. Appreciate it.
yeah, thank you. You're welcome. Thank you very much.
Thanks a lot to
Okay,
everyone.
so bye.